We're live now. So good afternoon, everyone, and good afternoon, Dr. Sainath. It is a pleasure and an honor to have you as a guest on our Genomics Gupshup. This is the 5th episode, and we are so delighted to have you here. You're not just one of the most well-known medical oncologists in Hyderabad, but also in the country. And not just that, we are very, very, very pleased that you were also helped us in developing some of our cancer panels as well.
Yeah, thank you.
So thank you very much, and I would like to welcome you to Mapmygenome. So I'd like to start with a simple question, right? I mean, you're treating a lot of people who are, come to you with a lot of hope. So, cancer is a difficult subject for most people to reach. So how did you get inspired to become an oncologist in the first place?
So I never intended to be an oncologist. So when I was doing my MD, where we have this clinical rotations in different subspecialties, so I was posted in pediatric oncology. So figuring out what to super specialize on, I was reading one interesting sentence in a pediatric oncology textbook. It said that of all the diseases, it's infection and cancer where the goal is to treat. Rest all is you cure. The goal is to cure. Rest all you're treating them, be it diabetes, hypertension. They're all like lifestyle diseases. You get them, you can't get rid of them. You just manage them. So that word cure has inspired me, and I thought probably that's when I realized I should be an oncologist, and because you're attempting to cure, that made me inspired. And obviously infectious diseases, we are I think we are ahead in managing infections. The COVID is a big example that we could develop so many drugs and vaccines in a very short period of time. Tells that our research and our investment in managing infectious disease has been long, but cancer is still an enigma to most people. So that made me take up cancer.
It's very, very interesting that you said cure and not treat. But I was reading somewhere that a lot of the cancers are preventable as well, right? I mean,
Yes.
But I guess the ones that are there, there is a difference between. There are lots of different kinds of cancer. Right? So, from your perspective, since you treat pediatric patients, you treat adult patients, how, for a layman's term, would you say that what is the difference between one cancer versus the other?
So ideally, any cancer starts with the problem in the genetic event. So there is a genetic event which makes an unregulated growth of cells. Now, what makes, what enforces that genetic event is something which we don't know. What we know is that there are certain risk factors, certain things which will predispose to those kind of genetic events, and certain infections or certain very limited number of cancers where we actually have the causality. If you get this infection, your likelihood to get a cancer, something like chronic hepatitis B or HPV infection, we get. Apart from that, there is a lot we don't know why these random genetic events which lead to cancer happen, and the number of cancers. What we always thought was a single disease, even now we understand it's a heterogeneous disease. Like the best example is lung cancer, where we thought all lung cancer or all lung adenocarcinomas are seen in non-smokers and it. But the heterogeneity is humongous. Now we know that these genetic alterations are different in each individual. So we still don't know why that happens, but we definitely know that there are certain risks, and the burden of cancer can easily be correlated with the amount of risk factors in that population. So the quantum of risk factors in that population actually is defining the prevalence and incidence rates of cancer. Yes.
So I'm very curious. Clearly cancer. We are, like you mentioned, we are still figuring out a lot of things, right? I mean, there are so many types of cancers.
Yeah.
And I also read that 70% of the cancers now have a biomarker that is associated with it, and
Yes.
probably I think in the future probably all of them will. So how do you communicate? There are so many oncologists in the country and in the world, right? How do you keep track of all of this? Because clearly this is one of the most that area of medicine where lots of changes are occurring, right? So how does that communication occur in real time
with the patient.
with the patient and
So,
with physicians also? Right?
yeah,
How do
physicians.
physicians-
Yeah, I think there is a lot of ignorance, not only among the patients, but I think in the fraternity as well. So, a lot of people do think that cancer is a single disease. It's a heterogeneous, and even in a subtype of cancer, it's way heterogeneous than what we think of. Like right, like you rightly said, almost 70% of cancers now we have some biomarkers. So you have to look at it in the phases of how the cancer research has developed. So it initially started with identification and excessive surgical procedures, and then the advent of chemotherapy drugs, where it worked on the principle that rapidly dividing cells, the chemotherapy drugs would work much better, even though there is some collateral damage to the normal cells and tissues. Then came the genomics, and it got accelerated once the Human Genome Project actually was started, and when we got to know that, and the advent of so many sequencing methods, when there are a lot of recurrent genetic abnormalities which happen. I generally use a lot of analogies happening in the world to put it in a very simple language. I always say that chemotherapy is just like carpet bombing. So when USA invaded Afghanistan, this term got very popularized. Carpet bombing. The terrorists are hiding in a hill, so you just bomb the entire hill.
with the hope that
Yeah,
one of the
even the terrorists get, but there is a lot of collateral damage. That is what chemotherapy actually does. That's very simple language. So when you know the genomics, when you have the biomarker, it's more like a targeted therapy. You're like hitting the target, the genetic alteration, which happens only in the cancer cell. So for that to happen, and for that, it's more effective. So the language we have to use is not of the toxicity, it's more of the effectiveness. We are more effective when we target a specific alteration. So that's how I convey. So this is like a targeted missile, and that is like carpet bombing. So that's the choice. I think it instantly connects to most of the patients.
And you're one of the few doctors I know that very quickly, I think, use genomics in their practice, right? And maybe if you can help us understand, how do you use genomics in your real practice? And are there any challenges or bottlenecks that you feel
Yeah.
that are there?
So I think genomics previously was more of a prognostic, or was for the research purposes. Now, but with the current research and data, now it has become important for everyone to do genomics before they start any kind of treatment. So the genetic or a specific mutation testing for most of the cancers is required to decide upon the treatment. It's not only about the targeted therapy, it is also the futility or the utility of certain drugs. It's sometimes it's a negative predictor. Probably if someone has this mutation, these drugs are unlikely to work. So that predictive models have come. So that we have to often use. Now it has become a guideline. So now with any lung cancer patient, you don't jump to say you'll give chemotherapy. So it has come into the guideline. Apart from that, more importantly, as the disease is evolving, as the treatment is evolving, so is the cancer mutations. So now when you are starting with the newer drugs, you are facing a different genetic challenges. So you're changing the course of the tumor progression. So they are likely to develop another specific mutations. A simple example is EGFR mutation lung cancer patients, where we are using all these TKI inhibitors. Now, once we start them on those EGFR inhibitors, after some time, they are 50% or 40 to 50% of EGFR mutation lung cancer patients develop a mutation called T790M, which we hardly saw in the first go.
Because you didn't.
No, because we didn't. We only saw the mutations. We knew that these mutations would act with EGFR, and this is a path which actually started developing after we introduced TKIs. So you have to understand how dynamic the field is. So again, you come back, you do another. So you. So you need to do another second genetic mutation analysis after the patient progresses. So the impetus from only at initial diagnosis has changed to a dynamic process where you have to even do it after subsequently to see what are the newer genetic events which are happening, and then what else you should be using, and the changes which happen. So it's a diagnosis, at progression. This is where we are using, and sometimes when you have exhausted all options, when you do a comprehensive genomic profiling to see if there is any off-label drug which we can use in that particular patient, and sometimes it does help even though the percentage is 5. Having said this, the biggest challenge is you are dealing with a lot of data. You have got a disease, you are doing a lot of genomic analysis, and you got a lot of data. Now, how do you analyze it, put it in a perspective, develop a therapeutic model? What should be the sequence? It's like rather than finding a solution, probably we opened the Pandora's box. At the same time, achieving some tangible results. So, even though all these things are happening, our lung cancer survival rates have gone from 6 months to 9 years to somewhere around 2 years, 3 years. Like there are patients who have there still for the last 5 years. Which was never heard of, which we never saw before all these genomics happened in the last 10-15 years, probably.
So that has really helped us in sort of
Yes.
improving
Yes.
as the quality of life also become better, because like you said, it was carpet bombing, now you're doing more targeted.
Absolutely. I think more importantly, in a disease which has a lot of social stigma, when you say cancer, it's already most of the people or the people in society, the family, everyone registers. It's okay. I've already got my death certificate. I've been pronounced that you are going to die at some point.
But aren't all of us going to die at some point, right?
Exactly.
And we all have that.
Yeah.
We all have an end
exactly.
of life.
But it's like putting a patient on that time. You have this kind of thing. But that's a stigma. You're absolutely right. We know how unpredictable life can be, but still, when someone knows this happens, and
Still a difficult news for people to digest.
Exactly. So the impetus of the next thing what they ask is, I want to die with comfort, quality of life. I don't want to prolong my life at the expense of quality of life. So quality of life of late, even the oncologists and the drug development have shifted towards also looking at quality of life as an important parameter. So with genomics, with targeted therapy, the quality of life is definitely a big parameter. And the quality of life is now, in certain very elderly patients, it's the only goal. So quality of life has definitely improved with the newer drugs, and without genomics, we wouldn't have even reached there.
So one of the genomic tests that pretty much everybody knows is BRCA, right? I'm sure that must be the most commonly used test across the world, right? Which is the second most common? If there is a second most common.
I think MSI testing, microsatellite instability. BRCA 1 and 2, it's again germline, and sometimes we do even the tumor BRCA very rarely. Now, I think more importantly, it's the microsatellite instability. We never thought I still remember in my MBBS days when we were reading about this Lynch syndrome, familial colorectal cancer syndromes, it was hardly 2% or 3%. And you ideally, if you need to have a very stringent family history, someone 2 or 3 in the family should have it, then test it. We were doing Sanger sequencing and all those. Now, of late, when we saw that the percentage is actually higher than we thought, and even in families where there are no documented colorectal cancers, so it's definitely surprising. And then when we know that these patients, MSI testing is a predictor for a immunotherapy response. I mean, amazing 50% have response. The response rates to
That's
immunotherapy
impressive. Yes.
for MSI high patients, that's impressive. I mean, patients living with longer with good quality of these patients. So with that, I think MSI testing has gone up. Previously, we were only doing it for colon. Now we are doing it for endometrium. We are doing it for stomach. We are doing it for biliary tract tumors, pancreatic tumors. I think wherever. Now it's a tissue agnostic indication. Any cancer with MSI high, you can go for immunotherapy. That's a tissue agnostic indication. It's an approved indication.
So for the average person, what does immunotherapy mean, right? I mean,
This is a very, I think, a lot of misinformation about immunotherapy.
Which is why I want to, you to explain what
So, in a very simple language, so what happens is when a tumor develops, not every mutation translates to development of a cancer. Why does that happen? Because you have good immune system. So your immune cells, the T lymphocytes or the CD4 T helper cells, they have a mechanism to identify those abnormal cells, kill them, destroy them. Now, what happens is for the tumor to survive, they develop mechanisms to evade this immunity. And the most common pathway what we saw was this PDL1 and PD1 interaction, which is the PD1 receptors on the T lymphocyte, the immune cells, and the PDL1 is on the tumor cells. So they escape the body immunity and they grow. Now, what these immunotherapy drugs do is they just break that interaction. So now the T cells identify the tumor as a foreign body and they attack it and they kill it. So it's not the common misconception is that you're trying to build up the immunity of the person. No, you're trying to just break that immune escape mechanism of the tumor and you're allowing your T cells to do the job. So you're just exposing the tumor to your immune cells with the drugs and the immune cells attack the tumor and you get a response.
So you're basically using the mechanism of your body
Yes.
by making some small tweaks to
That's
sort
it.
of
That's
get
it.
back. So that's your, it's basically like trying to use, whatever it was initially thought it was going to be doing.
Yes,
it does
yes,
it now.
yes.
And
So what happened is there is now a big pseudo industry going on that we will improve immunity in cancer patients and you are getting like a lot of over the counter
We'll get a lot
supplements.
of immunity supplements. Yes. No, I think that's, but I did treat that, some of the immunotherapies, we still have to make it more cost efficient as we go along.
Yeah, I think the cost is again a big factor. I think we can
get there at some point of time.
Yeah.
So maybe if I can go into the head and neck cancers and the other cancers that when we developed this DNA Onconex, you mentioned, I remember this from the first meeting that we had, that you said that we try many of the other things that are there in our protocol and then eventually go to genomics initially because cost was a big factor. Do you think by changing the sequence now, by getting a genomic screen upfront, do you think that we'll be able to help a lot of our patients who might be at risk or are looking at the treatment options for head and neck or other types of cancer?
Yeah, I think if you look at the genomics in other cancers, you first have to have the data and the screen to see which is the subset which is doing good, which is doing bad, what are the genetic events which help you to know that the subset of patients who are likely to do good to certain drugs or don't respond to certain drugs. First, you need that data. Based on that, you develop modify or you develop a treatment algorithm like these genetic events, you are going to treat them differently, like what is happening in breast or colon or in lung. So that kind of an approach has been lacking in head and neck cancers. And why it is, for the obvious economic reasons, it's the problem of the third world. It's our problem. It's a smoking related problem. Most of the head and neck cancers are tobacco associated. So it's not the problem in the West. So and that's why if you look at the drug development, barring one cetuximab and an immunotherapy drug, there are no new drugs in head and neck cancers. in the drug development, in the pace at which they are being developed, as compared to lung, where on a yearly basis you're getting like a couple of 2 to 3 newer drugs. That's not happening in head and neck. So the bulk of research is ending in that. It's not, and it's a big problem for us. So I think it really helps when we start doing this to identify this. The second biggest challenge, which often we don't see, is head and neck cancers do have a lot of pre-malignant lesions. We don't know what are the genetic events which happen. And it's not like someone has a pre-malignant lesion, they would develop a cancer. Some would regress, some would progress. You don't know who. What is the genetic event which makes them more likely to progress? Now, when you know that kind of information, you are likely to develop a better treatment strategy for these patients. And often, these patients, this is a common cancer in the lower socioeconomic strata because of the primary education or the hygiene. And there are a lot of traditional forms of practices like reverse tobacco smoking, areca nut consumption, pan masala. These are all new. I mean, these are all very pertinent to our context. We don't have any data, genomic. I mean, surprisingly, we don't have any genomic data about this thing. Yet, it's a very common problem for us.
I remember one scientist in the US saying that they had done a lot of these studies many years ago, almost 15-20 years ago now. And what he mentioned was exactly what you said, which was that the challenge is that most of the large pharma is probably not going to touch this because of it's not really a big enough problem for them to solve. But there is obviously the gutka, the pan masalas, and the others. I think some of them are in some of the upper strata, but I guess still limited to India in many ways.
Yes.
So I guess there's a big dose of education that we have to get to the general public, because I guess
true. And the point is, with education, you're not likely to get any easy results, early results for the next 15 years. Even if we do it on a war front now, the results will come after 15 to 20 years. Because what are you going to do about all the patients who have already been exposed? Their risk doesn't come to zero the moment they stop smoking now or they stop chewing tobacco now. They are still at risk of that cancer for the next 15 to 20 years.
And that's true even in lung cancer and others also. Right?
Yes. So that's a huge problem. You have a very huge public health problem in front of us in terms of head and neck.
So do you think that if we had some way of doing an early screening, part of the education programs, do you think that will help us in bringing about more awareness and as an early treatment, if that was possible, at least in some types of cancers, maybe not in all, like some where there is, I read that breast cancer in the US now is fairly well treated because they catch it early.
So I think when it comes to screening, 2 to 3 things are there. One is whether the screening is effective in identifying the disease early. If you treat the disease early, is it going to improve the survival, the cure rates? These are very important. So whatever the approach to screening which we have taken is a bit flawed. So a lot of screening studies, until and unless you show a survival benefit, that screening method is not approved. So if we have to use the US strategy of doing a yearly mammogram, it's still a big public health expenditure for us. The second most common cervical cancer also. But yes, there is definitely a decrease in mortality, awareness, and this thing. Screening without your good genomics, you are just going to spend too much, at least in the Indian context. Now you have a lot of other cancers like oral cavity cancers, which are again tobacco associated. Here we need a screening, even though there is no recommendations in the Western system, because your baseline consumption rates are high, your baseline tumor incidences are high. So screening will help us in early detection, decrease morbidity. It has an indirect effect on the cost of care, and which is a significant important outcome. A lot of patients end up having a delayed diagnosis for the fear of the cost of treatment. Early screening and a lesser intense treatment would actually cut down on their costs, improve their longevity, improve their general overall condition, and most of these people are the sole breadwinners. So it has a very indirect effect. I mean, the measure of only a survival will again be flawed in such common cancers. So I think screening is definitely needed, and if we join the genomics with us, and if we create a genomic data, the first step is to create the data, use it, analyze it, and how well we can use it to decrease the mortality. I think the answer lies there. Screening alone, again, your results will be minimal. It's a huge effort with minimal results. You need to amplify the result, you need to add genomics to it, you need to do it in a very smart way.
To the extension of my question, like for example, any patient who has cancer and their relatives wanted to know their risk factor, what kind of advice you give to them? If they want to know their risk of their, for that cancer, there will be obviously some people who will be asking them.
So, a lot of these cancers, there are, if you have to look at the etiology or etiopathogenesis of the cancers, there are certain things where there is a certain genetic predisposition. They are not associated with any exposure to the environment. See, human body is very unique in the way that there are certain organs which are exposed to the environment, and certain organs are not exposed. And the cancers in organs which are not exposed to environment, there is definitely some familial component, like breast, ovarian cancer, endometrial cancer, so colon cancer, gastric cancer. When someone has these cancers, definitely a genetic screening at an unusual age, at a younger age, it really helps to know what are the genetic predispositions they have. What we found is the tip of the iceberg, BRCA1 and 2, and MSI testing. What we are doing for the familial screening, the common BRCA and MSI testing, it's just the tip of the iceberg. There is a lot more. Why do I say this is, if there are 100 smokers, say 30 would develop cancers. What is there in that 70, the genetic makeup, that they don't get cancer for an equal tobacco consumption or this thing? So it's a dynamic thing. There is an environment risk, and how your body or your inherent genetic makeup responds to it, and combined to that your habits, your nutrition and all this. So it's a very complex problem, but definitely I think the genetic makeup of a person does matter in cancer. We need more research in that.
And so, do patients come to you and ask you for guidance on, my mother had breast cancer, my aunt had breast cancer. What should I do in terms of nutrition? And do patients come currently to ask for guidance for prevention rather than for treatment, or not that much?
It is confined to the caretakers. So until someone in the family has a cancer, the rest of the family they don't get alerted. Yeah, they get alerted and they do ask for the tips, and is there any preventive strategy? What else can we do? And is there any genetic risk or that? But looking at the patient's clinical profile, the affected family's profile, we do suggest certain things to do. But there is no perfect solution for it. I always tell them that you have to be healthy. That doesn't mean it prevents the disease, but it will definitely help you if you have a disease to fight the disease.
So overall outcome of the disease is effects.
Yes. And the simple example is the cancers which the farm workers get. Those who work in the farm, in the sun, they do a lot of physical work. Their tolerance to chemotherapy is very much high as compared to the people who do a lot of desk job. So that's a very interesting observation, that's the reason why you need to be healthy. Your tolerance to the therapy is also much better. You are in a better position to actually fight the disease. So that's the disease. So if it doesn't prevent the disease, why should I be healthy? I mean, that's not the thing which you should be thinking. It will help you fight the disease better.
Absolutely. I think in most people forget. They either say that, it's in my genes, so I will get it. So I will do nothing about it. And then there are some who say that, I saw this other uncle or who smokes and still didn't get anything. So I think people forget that each one is you are yourself. And
Yes.
in your case, what your genetics is doing, what your how your general health is,
Yes.
what your nutrition is, all contribute to the disease.
There are a lot of variables. You can't decide on a single variable. So it's the combination of those variables where the probability of having.
So we'll move on to pediatric cancers. You are obviously you have so many things you can do. We can ask you hundreds of questions, but pediatric cancers are very special. I think I was listening to one of your interviews or one of your videos where you said that they are very different from adult cancers. So I'm sure that you mentioned they are also more curable. So does it, from an emotional point of view as a physician, how does it feel when you're treating someone, a child who has a cancer? It's obviously a very difficult thing, but at the same time, it's also something that you can treat. So how does this whole?
It's to put it, it's emotionally draining as a physician. Honestly, a kid with a cancer, it's emotionally draining. How well professional you want to be, that's that. But the only thing is, because almost 80 to 90% of pediatric cancers are curable, the outcomes are so good, you're ready to invest that kind of emotions into the child and you treat them. The outcomes are satisfying. And the pediatric oncology, the direction of the research has more been in decreasing the long-term effects of the treatment. How do we, you know, strategize and how do we stratify the treatment, decrease the toxicity? The direction is in that direction, and for very few bad diseases, bad cancers in kids, how do we break them? So most of the direction is in that. But having said that, almost 80 to 90% of pediatric cancers are curable. So it's very extremely gratifying. The more important is the care involved. It's not the drugs. It's the care involved, and the intensity of the care involved, and a lot of the time it's the family support. They need to be convinced that the child will be normal. He will have a normal life. Everything comes down to that when it comes to kids. An adult patient with cancer, uh, he has a bone cancer, and sir, it's okay. I mean, he let him lose the limb. If he's alive, it's good for us. When it comes to kid, they not only want it to be cured, they also want them to have a normal life. So the parents need to believe that it is possible, and they need to invest in that. So a lot of that actually happens, and a lot of there is gender disparity also. If you look at some of the government organizations where they treat pediatric oncology, all the sex ratio is 2:1 for all cancers. It's more in males. It's not that it's more in males. It's that less and less girl child are being treated. I mean, who is going to marry a girl child who's a cancer survivor? So even that kind of thought process is there, even for highly curable cancers like Hodgkin's lymphoma. So it's a lot of a social investment by the society, by the treating physicians, families, and society as a large to take these stigmas. I mean, that the challenge lies there rather than the disease and the treatment.
So it's more an environment and our own
Yes.
Misbeliefs, I would say,
Yes,
or
yes,
biases that
yes, yes.
contribute to making the problem
Yes.
more.
Yes.
More
Definitely.
severe.
Yeah, we are making progress, but I think we can do much more. We have reached from somewhere of cure rates to 30% to 40% to now we have around 60% roughly in India. I think it can easily go up to 80.
This pediatric cancers, as you told me, these are recurrent. Like what's the percentage of recurrence of this?
So most of the pediatric cancers are not recurrent. the relapse rates and all those things are less. Most of the time they can be salvaged as well. The problem is once they become a cancer survivor, the risk of a second malignancy at a later point of time, in their 30s or 40s or 50s. That again is at a very small percentage. It's not like every child is going to have a second tumor. That is there. And now I think probably if we go 15 years, 20 years from now, I think even that numbers are going to come down because you are changing your treatment, you're risk stratifying your patients. You're de-incentivizing your treatment in a low risk patient. You're intensifying it only in high risk patients. It's not like one size fits all therapy, even in pediatric cancers. So I think because of the lesser drugs which you are using, you will see the overall incidence of this secondary malignancies also will go down. I think we need to just wait for another 15-20 years for those results to be visible.
And I mean, when you classify these pediatric cancers, I know blood cancer is one of them. What are the other common pediatric cancers that?
So I think one is the blood cancers, acute leukemias, lymphomas, sarcomas, and brain tumors. These are the most common. And in adolescents, it comes down to bone tumors, osteosarcoma, Ewing sarcoma.
And can people easily identify that this is a cancer, or how do they first go to a doctor, right? I mean, if they're in some village, how do people identify that something is wrong with, that it's a cancer?
I think to begin with, your child will just not be the normal. Anyone's child will be not the normal self. It's kids don't hide their emotions. It's very evident. Something is uncomfortable to them, they do. It's evident in their behavior. It's unlike adults. So I think that is one thing. Something very regularly change in this thing, and obviously any swellings, lethargy. They're playing less, they're eating less, they're getting something which is not resolving, fevers not resolving, and all these things are a sign, subtle signs.
So you are also involved in some charitable works, if I understood correctly, right? And can you?
So I think we as a team of Kaizen Oncology, we started a pediatric oncology center in Sivananda, where it's a collaboration where the building is supported by someone. The drugs and the consumables are again supported by another impact organization who have been very kind to us. We have been providing our clinical services to the center, and I think Dr. Sudha has been in forefront in seeing that this program becomes successful. That's one of the charity which we are doing. Apart from that, we are also involved in certain scientific work, especially we as a part of a consortium, Science and Cost Cancer Consortium, where we are looking at the evidence to develop evidence to reduce the cost of cancer care in India. Even though there are a lot of treatment strategies available, the equally effective and least expensive treatments are there not. So we are just looking at a research model for that. Now, going ahead, we also want to do certain big projects and studies, use a lot of genomics and bring the cost of treatment down, which is very important for us. And ironically, it has become a big factor even in the West.
Of course, I think it is still a high.
Yes,
cost.
I mean the out of to a surprise, I think the recent US survey about their own population say that there is a lot of out of pocket expenditure for cancer patients as compared to patients with other diseases, even in the US. And now they started looking at these issues, but and we have got actually certain good.
I saw one publication that you were co-author of.
Yes. The low-dose abiraterone, which was actually based on a phase 2 study by the great Ian Tannock. And we just followed it up and we said that the cost involved and the cost savings you are doing. And I think we got a lot of huge response across the world for that study, which we as a group, Science and Cost Consortium, which we did. So we are working on several those things. And one of those very prime important thing which we want to do, like you said, the immunotherapy's cost is very high, is low dose immunotherapy. So if you look at the newer immunotherapy drugs, if you look at the early phase trials, there are significant responses even with low dose immunotherapy, and you're cutting down by using a low dose immunotherapy. You're actually cutting down the cost by 80%. 80%. That is
80%.
80%. That's huge. That's huge for a country like us. I mean, across the world. So again, it's the impotence and it's our problem. So no one is going to do a research on that. We need to do that. We need to find solutions to our own problems.
And I mean, of course, there are many more questions, but maybe I'll ask you one question on. You worked on the outcome of pediatric Hodgkin lymphoma, which was treated with ABVD. Can you shed some light on the same?
So I think pediatric Hodgkin's lymphoma conventionally was treated with different protocols across the world, and a lot of these protocols had they were done in cooperative groups, with every study having an intention to decrease the late long-term toxicity or improve the survivals and all these kind of things. But those complex protocols are practically impossible to use here, given the schedules, given the toxicity management, compliance issues. So most importantly for us, it's to have that compliance issues. And this ABVD regimen was a common regimen used in the adult patients. They just we adapted that regimen for years to treat our kids with Hodgkin's lymphoma. So our work was to show that the results were equally good when you use those complex protocols, where a lot of supportive care, a lot of out of pocket expenditure would be high had we gone to those protocols, the US and the German protocols. Now for us with this one, I think even an adult oncologist can treat any child. That's what we were able to show, that your efficacy is same, your toxicity is same. We recently published the long-term toxicity data also with this one, because that's where most of them would just say, probably it's too toxic, the long-term side effects. So we showed that the long-term side effect is also not a big problem, and it's a very safe and effective for any resource-limited setting, and even the adult oncologist can safely use that regimen in kids.
So one last question again. What do you think is the value of genetic counseling in clearly cancer oncology? When you're treating a lot of cancer patients, and you mentioned this, that a lot of them need care. So how important do you think is genetic counseling in this?
I'll just start with one very basic concept, which is very difficult for general public to understand. The concept of chance, the concept of probability. I don't think we as a nation or as a world, we understand that concept of chance or probability. We need to put it in our education system. So when we say that the probability of something happens, the understanding is less. And now what the consequences of that is, in this today's world of social media and everything, there is a lot of misinformation. There is an infodemic of misinformation. So when such things are there, you need a specialized role to make people understand, when you do a genetic test, what it actually means, what it doesn't tell, how do you take home with that. If you don't do that, the entire work can be, it will just go down the drain, how high-end technology you use. So there is a very big role of genetic counseling. It's not, I cannot stress less. It's very important, because people would understand what do they mean by a probability. So genetic counseling pre-test and post-test is very important for any event which we do. And a lot of times these professionals are in shortage for different reasons. So we end up doing some of that part also. But obviously, you can't replace an entire role. So you're just doing a bare minimum.
We now have a very large team of genetic counselors, so hopefully we'll be able to assist
Yeah.
you in that.
Yeah.
Regarding this, we developed a small panel, as you know, and we are into market from past 1 year. But as a you might know that many people from oncologists and all, they prescribe genetic test, to do this thing. But there are lots of other, oncologists also that test it, because sometimes we get the clients with just a prescription saying that I have this cancer, I want to do a genetic test. We always ask them that whether your doctor recommended it or not, and they wanted they want to know that even doctor doesn't recommend. Is there any genetic test which tells us that whether there is any scope for choosing the drugs with the test or not? Whatever education that we need to have from our as a service provider of genomics to educate other oncologists also that these things will work.
Uh, like I said, I think you need to have the purpose why we are doing that test. Is it to stratify the treatment, or is it to look at the events where after a certain kind of therapy, to identify any new events which have developed, the ability of those the test to identify them. And third is you're just doing it because all the standard treatment options are finished. You're just looking for a marker where you can use an off-label drug. That one has to be very clear. So until and unless you know the purpose of why you are doing what you are expecting from it, you will end up in a ocean of nowhere. You will not know what to do with that report, and you don't know how to go forward. So I think you need to have a very clear cut idea why you are doing that. So a lot of times we do send as a last option when patient has exhausted all the treatment options, we end up doing comprehensive genomic test.
I
But
think it's,
small genetic tests like GFR and all, they will be advised in the starting position only.
Yes.
to the treatment.
Yes, that's what. So the purpose is very specific. Why are you doing? Does it have a treatment implication, immediate treatment implication, or you have already run the test once? Now you want to look for any additional genetic events which is likely to alter your treatment.
so I think his question was more that sometimes we're getting patients who are directly coming to us.
Yeah, no, I think
And-
we
and
have.
How do we educate or not educate, but how do we get more physicians to sort of use this? Because clearly patients want to know that, right? And I think patients are not the best judge of
Yeah.
what they need. But how do we enable the physicians to sort of say that, maybe these are how it will help you, right? And I think the more the physicians know, then I think the easier it is for the
Yes.
patients also to get a good guidance.
I think more importantly, what when this field has just exploded, the genomics and this thing, what needs is a comprehensive interactions or meetings to actually educate about the intricacies, the pitfalls, the do's and don'ts. What as a genetic service provider you will be able to tell the limitations of that, and what is the thing which we want. I think there is a lot of a discrepancy in what I am expecting as a clinician and what you actually can provide as a genetic service provider. What are the limitations? So I think if it's only by an interactions and educative CMEs where you understand your limitations, and then you can use your test more effectively to know and at the context in which you are using it. So if you don't have the context, it's all in the language of computers, it's GIGO, garbage in, garbage out.
One basic technical question is there. Like, for example, all the oncologists, they only take they only take out the biopsies and they give to pathologists, they put it in FFPs and then make the shift. And the pathologist, histopathology will be done everything on the block. And after everything is done, leftover block will be given to the genomic person, whether it is such a small one or big one. Then that is the only one we have to make it work. Is there anything like that has to be taken care while taking the sample out? Sample collection procedures.
Yeah, I think we have started sensitizing our interventional radiologists, especially in Milan. We started telling we need a good core.
Okay.
You give one core for the tissue diagnosis, we need another core for genetics.
Yeah.
And we started sensitizing even the saying that, don't run any IHC marker if it's not required, just to have an establishment. Clinically, it looks lung, it's nothing but lung. So, if we can forego IHC and use that sample for genetics, this one. And I think of late, the pathologists have started also looking at the quality of the sample. Previously, they wouldn't do, they would just give the block and send. Yes. I think still majority do it, except the cancer centers where we are sensitized to these things. But a lot of this information has to go into the public. That's very important. I think public in the sense the practitioners, the radio, the interventional guys, the pathologists, that it's very important for us to have certain level of sample to actually run a test, to extract DNA, to run the test and everything. So I think one can start with a simple educational material or a CME kind of a thing. Involve these guys, what are the limitations we have. I think that's the way, because when we as a clinician, when we face the patient saying that the sample was
face the patient more
directly, that's when we started sensitizing our radiologists and pathologists. No, this is very important. We need so many number of cells. Even for a cytology cell block, we said we need so many amount of cells. Should we go for it or not?
So, sir, what do you think is cell-free DNA role in cancer? Is it that the practitioners actually are doing that now?
They are doing, again, it's like we have just opened the Pandora's box. We don't know exactly how do we handle it, how do we modify it, how are we going to use it in treatment. So, cell-free DNA gives certain answers. It answers certain things. It answers tumor heterogeneity. It answers tumor heterogeneity and these things. But is it a foolproof technology to identify all the genomic events in the body? No. But still, so you always use combination of this paraffin-embedded blocks, cell-free DNA, circulating tumor cells. Sometimes you need to have. So we don't know. We don't have the entire scope. And this is a dynamic field. This is going to be dynamic field. I mean, just now what are the resistance which will happen when you use a first-line ALK inhibitor, which you don't know 15 years back because there was no ALK inhibitor. Now we are using ALK inhibitors. Now when you use certain kind of an inhibitor, you know that these are the resistance pathways which will develop. Again, you need a test there.
How do you create these SOPs for everybody to use? Right? Is there some central body that does?
No, unfortunately, we don't have it. Like I said, there's a lot of work to be done.
I think there was this new establishment of the cancer network, right, within
Yes,
India.
yes,
Maybe that's the first good start in terms of getting to that.
Yeah, I think it's just starting to. It's very rudimentary, or there it's just preliminary stages. It's more of collaborating data, collecting data, and trials, few trials, clinical trials. I think in genomics we are still far away. We are still far away. And we can't be behind because you will not have good effective therapies. You are likely to have ineffective therapies from the West because
the genetics.
The genetics and this thing, what is the biggest problem is you don't know what is normal for your population. Whether it is a polymorphism, whether it's a variant of unknown significance, whether it's a normal polymorphism, variant of unknown significance, or whether it is a pathogenic mutation. Like we are doing BRCA1s and 2s, and I am sure 10 years down the lane, there will be a lot of mutations which you will actually tell are, not pathogenic, and there will be a lot of mutations which you will tell pathogenic. So you are likely to develop that data 10 years from now. I mean,
I think the more we get patients now,
exactly. So the more the testing improves you. So if that is there for only BRCA1 and 2, what about
the other things.
the other genes? So you need to have your own data, and I think that's where everything lies.
I fully agree. So I think getting more data, that's part of our mission also to help. But I think this was such an amazing talk. I know we can go on, but I know you also have a meeting, so I will close this over here. But thank you so much.
Thank you.
This was absolutely wonderful. I think maybe the key point that I took, and I think there are many more key things that were there, is that one is that I think cancer is constantly evolving, and pediatric cancers are slightly different from adult cancers. The good thing about them is they're very treatable. Use of genomics is going to help us quite significantly in terms of how
It's
we
going
care.
to stay.
It is here to stay, and we need to invest more now to be able to get to use. And also, I think I think if we have the passion and the purpose like you have in our community, I think we'll be able to get much further. So with more, I think we also as testing companies need to step up a little bit in terms of how much education we can provide, and
I think the days of working in tandem have gone. Now this is the era of collaboration in oncology, at least in India. I think you need genetic service providers, you need clinicians, you need drug development companies, and then you need the big pharma.
So we need everybody to work together, and we need to change some of the syllabus maybe in the medical.
Oh yes, you need to change a lot in medical this thing.
Correct. So I think all that will really help us, and I think we'll be able to be at par or if not ahead of the rest of the world. So thank you very much. It was an absolute pleasure.
Thank you.
Thank you.